Okay. This webinar was originally written by Patrick Hendry as part of the SMI Advisor Center and was originally presented on December 13th, 2019. SMI Advisor, also known as the Clinical Support System for Serious Mental Illness, is an APA and SAMHSA initiative devoted to helping clinicians implement evidence-based care for those living with mental health conditions. Working with experts from across the behavioral health clinician community, their interdisciplinary effort has been designed to help you get the answers you need to provide the best services possible. If you are a physician or a psychologist and are interested in continuing education credits for this webinar, you can contact the American Psychiatric Association. This webinar is being presented by Patrick Hendry, Vice President of Peer Advocacy Supports and Services at MHA. Patrick has worked as a mental health advocate for over 28 years. His areas of expertise include peer-provided services, self-directed care, social inclusion, and recovery-based trainings. He has led the creation and release of Mental Health America's National Certified Peer Specialist Credential, the first national advanced mental health certification in the nation. In 2014, he developed MHA's social inclusion program, Peer Partners. Patrick is the recipient of MHA's Clifford Beers Award, SAMHSA's Voice Award, and Eli Lilly's Reintegration Lifetime Achievement Award. He supports the inclusion of peers throughout the behavioral health system. Some final notes before we get started. At the top of your screen in the gray Start Meeting box, there's a chat bubble which you can click on to open up a messaging window, and feel free to drop any questions in there and we can go through them all Q&A style at the end. And also we'll be recording the webinar and sending that out along with the slides afterwards. So with that, I will turn it over to Patrick. Patrick, I'll give you control of the keyboard, and you should be good to go.
Thank you, Emily. And I just want to start off by making an announcement. This webinar, the reason why we're redoing it, even though it was presented in December originally, is because it's the first step in a new Mental Health America initiative to combat the pervasive spread of loneliness throughout our culture. A lot of other countries, like the United Kingdom, have already taken steps to address this condition in a comprehensive nationwide effort. MHA has worked for decades to assist individuals living with behavioral health conditions who experience loneliness on a regular basis due to social exclusion and the rapidly changing nature of our society. But the problem's larger than behavioral health. It is a rapidly expanding condition among all segments of society. In the United Kingdom, the Joe Cox Commission on Loneliness, and we'll talk a little bit more about that later, seeks to start a conversation on how they can ensure that their future is one of connection, kindness, and community, not isolation, separation, and loneliness. MHA is joining in this effort and will be partnering with other organizations to address this problem. So this is something that we're very excited about, and we really realize that loneliness is rapidly expanding in our culture, and it needs to be addressed on many different levels. And I don't have control.
All right, let's see. All right, I can just go through it for you, Patrick.
Okay. Just want to start off by saying that there's no conflicts of interest with anything in this webinar today. Next slide, please. So there's a few things that we want to achieve by doing this webinar beyond just announcing, that this is going to be a primary focus of Mental Health America going forward. At the conclusion, we hope that you participants will be able to identify negative psychiatric and physical health effects of loneliness and social isolation. We hope that people will be able to describe multiple ways in which individuals, communities, and society discriminates against individuals with serious psychiatric disorders, resulting in exclusion and loneliness. And then we also want to be able to evaluate the positive effects of peer support on assisting individuals in connecting into their communities and establishing friendships and personal relationships. Next slide, please. So loneliness is a big topic, and there's two primary aspects to it, in particular in behavioral health. There's the feeling of isolation that many of us feel, kind of a feeling of exclusion. And this can come about because of societal attitudes, which we normally would refer to as stigma. It can also come about because of what we can also call self-stigma, where we feel that we're not worthy of having relationships with other people. And sometimes it can be a symptom of what we're going through. I think a lot of us over the years who've experienced these kinds of problems in our lives have had times where we isolated, that we stayed, maybe we were afraid to go out, maybe social contact was just too overwhelming. Human beings are a social species, and they really depend on social connections. And without them, we don't function to our best ability. Loneliness has been linked to various psychiatric and physical disorders and early mortality. So we know that it's an important issue that needs to be addressed. Next slide, please. Have to excuse me, I've got a little sore throat today. So let's talk about some of the benefits of social ties. Social networks and our ties to other people have a real beneficial effect on both our mind and our body. It's a whole health type of effect. And when we find ourselves without them, we begin to feel a sense of distress or that something is out of balance in life. By providing emotional support and friendship and opportunities for people to participate in community, engage with other people, we offer people a chance to regain, if they've lost, their self-esteem, their feeling of belonging, of coping with depression, and a sense of well-being is kind of the result of having satisfying relationships with people of our own choice. And too frequently, I think in the history of behavioral health treatment, almost every facility or agency that provides behavioral health services generally has some kind of social connection program or community program, but they're usually not that effective because they don't reach people on the deep enough level to get them to actually change behavior. Changing behavior is very difficult. And so we have to appeal to people on a level that really means something deeply to them. And when we talk about loneliness, because of the fact that we are a social animal, it's not too hard to get to that place where we understand that the need to change is paramount. Next slide, please. So talking about social connections, we do know that people who have strong social connections have a 50% increased chance of increased longevity. It does things like it strengthens our immune systems and helps us to recover from almost any type of disease faster, and it's very good for our mental health. So it's really important to make sure that we're addressing that part of our lives. And we as peer support people, this is something that we can have a real effect on. So many people particularly people who have become very symptomatic at a young age, they never really learn. They don't have the opportunity to learn some of the necessary skills to exist in a connected way to society. So they really don't learn those skills for building relationships, particularly like intimate relationships. They're not as comfortable in social interactions because they've felt excluded for so much of their life. Peer support offers a pathway for people to find ways to connect that are comfortable and are specifically tailored to the individual. Next slide, please. So we do know, for instance, that people who have connections have lower degrees or levels of anxiety and depression. And that's very, very true. I mean, and if you think about it, it makes total sense, too, because when we don't go out and we don't meet new people and we don't have those connections, that alone is depressing and anxiety producing. And when we start off with anxiety and depression, and don't connect with people, nothing is going to change. But when we do find ways to build supports around ourselves and connect with things that are greater than ourselves, then we begin to have an effect on that depression and anxiety that we started off with. People who are, have small amount of social connections have increased vulnerability to anxiety and depression, antisocial behavior, and even suicidal behavior. And so when we have those feelings, it increases our rate of feeling excluded or feeling isolated. So it's kind of a problem with, it comes at us from two different directions simultaneously. A fairly recent survey showed that the lack of connections and loneliness predicts vulnerability to disease and death beyond traditional risk factors like smoking or blood pressure or lack of physical activity. So we know that whatever's going on in our brain because of those feelings of non-connectedness or exclusion or loneliness, we know that that's having this dramatic effect, lowering our immune system, creating all kinds of opportunities for other physical problems. Next slide, please.
All right, stuck again. Hold on. There.
That worked for me. If I can get it. Now it doesn't work for me. Okay. Sorry, everybody. We seem to have trouble with this platform about every other time we do a webinar. So when we talk about the feelings of exclusion and inclusion and even loneliness, it's very subjective depending on the culture that we've grown up in. We basically feel excluded when we feel alienated. In other words, when we feel like society and people don't want us or don't accept us. And the cause of that can be based on attitudes in the community, can be based on economic situations. People who live, in poverty have less opportunities for making connections, for being active in their communities. It can be affected by employment and how we're treated. And it can also be affected by and also affect our feelings of equality of rights. We feel included when we feel where we are where we should be, with the people we should be with, and as the person that we really are. And that's a fairly complex sentence to put together, but if you think about it, the times in your life where you feel like you're in touch with the world around you, and you perhaps have had those opportunities where you feel like you have solid friendships and the type of support that you need, the world feels right. You feel comfortable in your own skin, in your own body, in your own mind. Exclusion and inclusion can be very fluid. We can go from feeling one way to another way based upon things that happen around us and just the attitudes of others. And so particularly people who have experienced feelings of isolation or exclusion are much more sensitive to that. So these feelings can be tied to expectations and norms of our culture. So people expect us to act in a way, and perhaps we're a little bit different, and society pulls back a little, which then results in us pulling back more. So it's just a problem that tends to feed upon itself. Next slide, please. So like I said, these feelings of loneliness in particular are really subjected and influenced by culture. Cultural norms affect the manner, the degree, and the timing of how we experience loneliness. Cultural norms also affect how we express our feelings and what's going on, and our ability to communicate with others when we have these kind of feelings that make us feel separate. Levels of loneliness differ significantly across cultures because some cultures are based on community or family, and a broad family and a broad circle of friends is the natural part of that community. Whereas some other communities, for instance, Western society, like the United States, tends to be more independent in nature. And so some research has shown that people who grow up in cultures that focus on interpersonal connections, like family, extended family, and friends. They have a stronger expectation of connection, and so they may be inclined to feelings of loneliness just when they don't have the degree that they grew up with, whereas another person might be totally satisfied with the degree of connection that they feel. So that's how culture can shape our feelings, and so there's no one way about it. We also know that individual cultures that people who grow up in cultures that are more independent are far more likely to blame themselves for feelings of loneliness than they are to blame the society around them or other people's attitudes. Next slide, please. So we can start to talk about culture in a number of ways. As I said, people, depending on your cultural background, and for instance, in Western society, even in Western society, there's strong variations based on culture. If you even take two fairly similar cultures, like the United States' broader sense of culture, even though we have representation of virtually every culture in the world here, but if you take kind of the broad sense of culture and you compare it to a place like the United Kingdom, to England, a country that we have a lot of connection to, but our social attitudes are very different. Americans tend to be more plain-spoken. They tend to share their feelings more easily. People who come from countries like England in particular and Scotland, less so in places like Ireland or Canada or Australia, but certain areas people tend to be more private about talking about themselves, which then affects how people describe their symptoms or whether or not they even reach out for help. And so when we do this, that determines how society is going to react to us. And we have within our culture, we have people, as I said, from people coming from all over the world who've grown up in different kinds of circumstance. But when we look at people with behavioral health issues, there tends to be some commonalities, and part of it is the symptoms themselves tend to be the same, maybe expressed in different ways, but the symptoms are fairly much the same from culture to culture. The meaning of those symptoms, though, differs, and therefore we react to the importance of our symptoms in a different way based upon our culture. This, in turn, makes people around us react to us in a different way. And so, again, it goes back to that same kind of snowball effect that I've been talking about. So we always have to keep this in mind, particularly doing peer support work, that it would be wonderful if in peer support we were able to always match with the people we're going to provide support for. In other words, that if we come from a culture that talks about our health in very guarded ways, tends not to share about family problems, tends to keep things within the family or within that tight-knit group, and are less likely to reach out for behavioral health services even. If we could connect those people with people who came from that same culture and had similar experiences in their life, it would be far more easy for us to serve people with peer support. We don't have that availability. Even though there's somewhere between 35,000 and 40,000 certified peer specialists in the United States, we still can't match each person. And in many places around the country, a community mental health service might only have 1 or 2 or 3 or 4 peer specialists available for services. Next slide, please. So the other thing that happens is that when we start feeling these things of exclusion and being left out of things and feeling like we can't be a part of the world around us, particularly people from a more independent background, really begin to self-stigmatize. In other words, we start to blame ourselves for our situation. Certainly, as I said earlier, people from Western culture tend to blame themselves for feelings of loneliness far more than other people do. And yet it may be something that's being caused strictly by, it could be where we live. It could be our distance from types of activities. It could be related, as I said before, to symptoms, or it could also be related to the way other people have treated us. But when we start to self-stigmatize, a couple of things happen. For one thing, people who feel a lot of self-stigma compared to people who feel that they're receiving social stigma placed upon them by society around them. So people who self-stigmatize are far less likely to reach out for services. And this has a lot to do, and there's starting to be some really good research in these areas, but it seems to have a lot to do with feelings of worthiness and self-value, and we feel that we don't deserve help, or we're afraid to talk about ourselves because we, experience self-loathing. We blame ourselves for our predicaments, and then we don't reach out for help. So the bottom line is it only gets worse. One of the factors that can change that idea of self-stigma is working with a peer support specialist, because one of the real strengths of doing peer support work is that we also are, in a sense, role models for recovery. And those of us who work in one-on-one type peer support frequently have opportunities to utilize part of our own personal story to talk to the people that we're trying to serve. And if we use the right parts of our story and we talk about perhaps how we overcame those kind of feelings of it's all our fault, we're responsible for our condition, how we overcame that, how we were able to then reach out, connect with other people around us, and those of us who connected with peers early on in our experience, our lived experience with psychiatric issues, are very fortunate, because peers are really good at building trusting relationships and helping people to feel much more confident and more valued in society. So peer support and the peer movement can really make a difference in moving this needle, this growing trend towards loneliness in Western cultures and other cultures too, but this growing sense of loneliness. Peer support is one way to combat it. And we talk about peer support most of the time, particularly in a webinar like this, in terms of its use in behavioral health. But if you think about it, peer support is effective everywhere. And it's been in existence for almost as long as mankind has kept records, that people in traumatic situations or highly stressful situations tended to reach out to each other and provide kind of mutual aid back and forth. We know, for instance, in some stuff I've read, that Roman soldiers who experienced what we would now probably call PTSD, but were experiencing those really heavy negative effects of the trauma of war and death, tended to band together in small groups to support each other. And we can see this going through history throughout. So peer support can also affect people who may not even have a diagnosis, but they're still feeling disconnection. Two groups that are very prone to the feelings of disconnection are young people, adolescents, who still haven't fully identified who they feel they are in this world and where their place is in this world, and then older adults. And the reasons there are tend to be more clear-cut. As you become older, you begin to experience a series of very natural losses. People lose a sense of identity when they stop working sometimes. And many people actually end up going back to work once they've tried retirement because of that. Because in Western society, we tend to also identify ourselves by what we do. So when that changes, we're not quite sure who we are anymore. We also start to experience losses in both our own health and physical abilities, but we also have losses of people around us. As we grow older, we lose people. It starts off for people perhaps in middle age when they, most likely are going to lose parents and grandparents. But as we get older, we begin to lose friends and we lose spouses, and we find ourselves in situations that we never planned for. And therefore, the ability of peers to reach out to each of these groups is really important, and we're only starting to learn how to do that effectively, particularly with young people. Doing peer support with young people has had some very deep challenges for us. But there was a program that SAMHSA did about 12 years ago called What a Difference a Friend Makes. And it was for younger people and young adults. And it was just about that, exactly, that having a friend can make all the difference for somebody who's experiencing the trauma involved in being diagnosed, being hospitalized, being, put into involuntary treatment. Having somebody who has your back, excuse me. When we first started talking about recovery in the peer community back in the 90s, talking about it on a broader level, a number of peer groups, and one I was working with, we did these surveys to find out what people attributed their own feeling of recovery to. And the most likely answer, the most popular answer for 3 years in a row, I remember, was having at least one friend, at least one person you could depend on, somebody who had your back. And that was kind of the jumping off point for feeling recovery. Next slide, please. So we know that we can interact with other people, but society is changing, and a lot of interaction now is taking place in new ways. When I'm an older adult, when I grew up, maybe for many of you, the same thing, the ways that I made friends were fairly clear-cut. I made friends with the people in my neighborhood. Well, we don't tend to have that same kind of neighborhood feeling much anymore. People are very transient. They move from job to job. We made friends in school. We made friends as we got a little older in our workplace. We make friends in religious organizations, churches, and other religious affiliations. And those are the normal and natural ways that mankind has kind of always made friendships. It's that village feeling of having a community that you're born with. But that's beginning to change. Communication is changing. We're finding that more people communicate online in different ways. And so a lot of people are struggling to find really effective ways to use online tools to connect people to each other in a way that is highly beneficial. And there are some groups that are doing quite well with this. The Mighty.com is one group that kind of offers an opportunity for anyone who is experiencing any type of health challenge or psychological challenge to connect with other people in a way that is very healthy and safe. We find that groups that are kind of self-forming, in the past, perhaps, when we were diagnosed and we might have received our services in a community mental health center, and that community mental health center might have had a drop-in center. So we might end up in the drop-in center because a drop-in is a safe place where nobody's going to judge you. You don't feel like you're being stigmatized by being there. But at the same time, it's very segregating. The only other people we're around are people with similar conditions to ourselves. So people have started to reach out and create cross needs type of supports. So there are all kinds of support groups that people can join, activities groups where people find activities that they like to do, and they find groups where other people like to do those same ones. They attend those groups, and it gives them an opportunity to be around people who like to do what they like to do, and this is an opportunity to make friendships. So we're always seeking, that different ways to do that, and for those of us, again, who've experienced a lot of loss due to symptoms, due to diagnoses, due to all of those types of social pressures, these new opportunities to create relationships are just going to increase. Social media, some people feel, creates disconnection, while other people feel it is very connecting. And so clearly society hasn't really found its best way to use the technology as quickly as it becomes available to us. Next slide, please. So, we know that that stigmatizing attitudes, in other words, people looking at us as being other, as being different, creates opportunities for people to discriminate. And there is a tendency in many cultures to always treat someone as the other so that we feel like it elevates our own standing in society. This is really unfortunate, but that's where discrimination comes from. When we attribute negative qualities to people based upon race or sex or ethnicity or any type of situation, then that discrimination becomes a destructive force in their life, but it actually becomes a destructive force in society, and we tend to become more fragmented. And, you know, we can see a lot of that in our society right now if we look at it from perhaps a political angle. Right now, our culture, the Western culture, American culture, is more segmented politically than perhaps it's ever been. And we haven't figured out the way back from that yet. There will be a way back. Society is constantly evolving. People are looking at this. But right now, it's like, if I believe this, then I can't be friends with you because you don't believe the same thing I do, so therefore we're enemies. An important step in recovery is accepting the reality of our situation without accepting the shame that other people project on us. I've never really liked the use of the word stigma anyway, because stigma kind of implies that it's something about you is the reason why we devalue you. And it really isn't about the individual. It's about the attitude of the person who feels that way. So lack of access to care and also social marginalization, those two things together can create an even greater feeling of isolation and loneliness for people, peers in our society. Next slide, please. We know that there are national groups that are working on this, and we know there's international groups working on this. You know, peer support had a lot of it in behavioral health, particularly in the mental health side. Peer support was used for many, many years, even probably centuries, in substance use. There's records of Native American tribes that formed social groups that got together because of the fact that they were having trouble dealing with the use of alcohol. There was a genetic trait that prevented them in metabolizing alcohol in the same way that perhaps some other people did, and therefore it was creating real rampant problems in their society. And what did they do? They created the first support groups for substance use. Mental health peer support really has its formal beginnings in the times of deinstitutionalization, which would have been the late 60s, the 70s, even into the early 80s. And this is a time when, in 1955, there were 550,000 people in state psychiatric hospitals. Now there's less than 50,000. Probably still too many, yes. But it's way better than more than 10 times that, 11 times that in 1955. So in the 60s, states started realizing that people weren't doing better in state hospitals, and by warehousing people in these gigantic facilities under very poor conditions because they were never well funded, and also society gave very little attention to what was going on in those kinds of places. So a lot of people were mistreated or not treated. So then states decided that they were going to lower the hospital population and put people back out in the community. Problem was that they didn't put supports in place to meet the needs of those people in the community. So you had hundreds of thousands of people, tens of thousands per year, pouring back into our communities without supports. And also many of them feeling that they had been brutalized by a very anonymous system of care where very little importance was given to their existence. So we had a lot of very angry people coming into the community with very few things that we could do to help them. And peers, survivors, ex-patients began to get together on their own and create support groups and develop different tools. And the whole idea of peer support which is, helping each other and meeting together. Even when you're in a job and your role is that you do peer support, you still build your relationship with the person you're going to support based on trust and based on the fact that you can empathize with their situation because you've had somewhat similar experiences in your own life. And so that's where this all started to begin and to build. Then some of those same people started realizing, if we're ever going to have a better system, then we have to participate in it. And that was the beginning of really the consumer movement, which has now really become the peer movement, is very, very widely encompassing. Next slide, please. So an interesting thing happened in the United Kingdom a few years ago. There was a minister, a member of parliament named Joe Cox, and you may remember from the news that when England, if you followed it at all, they were getting ready to withdraw from the European Union, and it was called Brexit. And she was strongly spoken person, member of parliament, about keeping people together and trying to maintain these relationships that had taken generations to build. But anyway, she was attacked during the time when all of this was under discussion and there were people arguing in the streets about it. She was attacked and she was killed by somebody. But before her death, she had started to realize that loneliness in the UK was not only a terrible social issue, but it was having a major effect on all aspects of their life, their economy, the cost of health care, wages, work production. Everything was being affected by people feeling disconnected. So she had started a commission to do a report on it. It wasn't completed until after her death, and it's called the Joe Cox Commission Report on Loneliness Report. And it was really interesting. And the Prime Minister at the time, Theresa May, who is no longer the Prime Minister there, but she looked at this, and her statement I really liked. She says, "For too many people, loneliness is the sad reality of modern life. I want to confront this challenge for our society and for all of us to take action to address the loneliness endured by the elderly, by carers, by those who have lost loved ones, people who have no one to talk to or share their thoughts and experiences with. In other words, everyone who feels lonely." And then she went one step further and she appointed a minister of loneliness. And that's amazing when you think about it. It actually became a governmental position to deal with this problem, and it was because they recognized how severe it was for them. Next slide, please. And I do want to add that there's a new prime minister and new government in Great Britain right now, and I don't think the position of Minister of Loneliness is currently filled, but the movement that they started is nationwide. They've come up with all kinds of ways to support people in loneliness by the creation of more social activities that are available to people without access, better transportation. They even went so far to have their postal service make personal calls on people that they delivered mail to. They had all kinds of government agencies where people actually reached out to people when they saw that they were lonely. People in banks would talk to their customers more. It's a very comprehensive and very interesting report and plan that they've developed. And this is what we want to see happen here to some degree. The root cause of loneliness is actually evolution, and there's been a lot of science behind this. Modern society is extremely different from the societies that we came from. We're such social animals at heart in our DNA that it doesn't make any more sense to talk about a person being lonely and that being a normal state than it does for hive animals like ants or bees that live in these collectives. Well, humans live in collectives. We've always gathered together, tribal basis, village basis, nation basis. every different type of way, by specialty, by all kinds of ways of sorting and achieving. We still tried to make connections, and it's built into our DNA. That in years gone by, and even in some societies to this day, there's a type of social punishment called shunning. There's also exiling people, in other words, kicking them out of your society, kicking them out of your group, your town, your country, your team. And for humans to experience shunning, which is where everybody acts as if you're not even there, you're not even in the room, they ignore you. We feel that on a deep, deep level. We feel social rejection in the same way that we feel physical pain. Next slide, please. So brain scans have actually shown that social pain, such as shunning or exile or being pushed away, activates the same regions of the brain as does bodily trauma. And that makes a lot of sense when you think about it. Think about the pain. We talk about the pain of loneliness. People talk about the pain they feel when they have a relationship that goes bad, or someone in their life leaves or passes away. We talk about pain, and it's actually true. There is a pain that comes along with it, because the same things going on in our brain as would go on if we experience some sort of trauma to our body. What that does when we feel pain is that we go into a kind of a hyper alert state, and it's kind of like with the fight or flight syndrome, where the body either gets ready to run away or to fight. And what that does is it also, because we're not really doing that so much in society anymore, we don't necessarily run away or have the ability to run away, and we don't necessarily fight. So we have to experience trauma in new ways, and it changes the way we think, because there's a lot of chemical changes going on in your body. So when we're lonely and we're feeling that pain of loneliness, it's very easy for us to misread what other people are saying to us. We might find them as being unethical or competitive with us or threatening to us, when really that's not what's going on. We're far less likely to see things from other people's perspectives. And so again, those kind of feelings just exacerbates the feelings of loneliness. Next slide, please. So we do know that there are some psychosocial interventions that are effective, and we're going to talk about some more programmatic ones in a few minutes. But peer support is a psychosocial intervention. It allows people to work with somebody who can not only be an educator and a supporter and a friend to some degree, but also be a role model, just by the very fact that they have come to a place in their life where they can actually offer assistance to the people they care about. So peer support aims to encourage people to think positively about their future and about the possibilities for recovery. And when we think positively, we're far more likely to take positive steps to increase our quality of life. We know that personal stories, are one of the most effective ways of making people understand the experiences of trauma and symptoms of psychiatric disorders and substance use disorders and any kind of trauma that we might experience. Personal stories are a very effective way of getting to people and reaching them on a level that they can understand, and then they begin to feel that empathy that perhaps before, since they didn't have a personal feeling about that individual, it was very easy for them to ignore them. Once you get to know somebody, it becomes a lot more difficult. Next slide, please. And that goes along with what's going on in England, like I said, where they have people in banks or in stores or postal workers creating a new type of relationship with the people they're providing services to, because when they get to know them, then they care. And then this changes the kind of the way society operates as a whole. And that's their goal, and that's the goal that I think we need to have in this country. So Mental Health America has developed a program that it reaches out to people who have experienced isolation and the feeling of not being able to connect with the world around them. And the program is called It's My Life Peer Partners. And it's a combination of different things, of peer support, of psychiatric rehabilitation tools or psychosocial tools, and self-directed care where the individual has control over the activities and the type of interventions they want in their own life. Right now, this program is in use in 6 states, and we plan to expand into more states this year. We are offering the program for free on our website. We're in the process of overhauling the program, so it might be better to wait a month or two, but we have handbooks on how to run the program. We have all kinds of tools available, and we have a structure. Next slide, please. So it was conceived as a peer intervention. It wasn't conceived the way that most social connection programs are, which is something being provided by clinicians or other people. We perceived it as it was a program that could be run by other people, but it would best be run by peers, and it's turned out to be true. It's done through a support group model where people get together and try to identify what their social goals are. And when people first come into the program and we have their first support group meetings, the group goes through this whole process of people trying to decide what it is they want out of this group, but what is it they want to make their life feel more complete. And we found that for so many people that will come to a group like this, the primary goal that everybody starts with is to find a friend or more friends. And so they start there, but then as they begin to move through the process of building friendships and supports, they see greater goals. So working as a team, each person in the support group goes through this whole process of goal setting, and then the team works together with that individual. They say, okay, your big goal is to find friends. So the team, then the group kind of strategizes, what are the steps you can take to find friends? And maybe the solution they come up with is, again, like I was talking about a little while ago, when you find something that other people that you like to do and that other people like to do, it gives you an opportunity to meet people you have something in common with. So the group strategizes that and then develops a plan. And for the next week between groups, it's the task of each individual to go out and carry out that weekly plan, which, my favorite story, and I've told it many times in many webinars and workshops I've done, but we had one woman when we were first doing this group who admitted in the group that she had never had a conversation with a stranger other than maybe paying a cashier or, going to some kind of office for a doctor's appointment or something like that, but had never actually struck up a conversation with a stranger. And so the group talked and talked, and the peer who was running the group, peer specialist who was running the group, arranged to meet with the woman individually, and they met in a coffee shop. It was Starbucks. And they met there, and they were talking about how can you begin to go after this goal of yours of feeling comfortable talking to people in public. And the woman had an idea. She felt invigorated by the atmosphere in that coffee shop. She liked it. There was a lot of people moving around, and there was a lot of talking going on. So her first plan was she was going to go to that coffee shop twice a week, and she was going to go at the same day each week, the same days, and at the same time. And she did this, and of course what she saw when she did it was the same people tended to be there because they were getting out of work, or they were on a break, or it was lunchtime, or whatever. But she would see the same people over and over. And I remember she was a few months into the program, or a few weeks into the program, when she wrote in her journal that she had said hello to somebody she recognized, And they said hello back to her and said, "Oh, I know you. You come here all the time, too." That made her feel so proud. I was in touch with her about a year ago, and this is many years after we started, and she still has her group of what she calls her Starbucks friends. And they get together and have coffee, and she can talk to people. And it's just, for her, this is exactly what she wanted. And so it filled the need. Next slide, please. So we do collect some information in the beginning. We have people go through a quality of life indicator. The one we use is called personal outcome measures, which measures quality of life as determined by the individual, quality of their own life. And so we take a baseline when people first come into the program. They go through a simple interview process, and it identifies areas where they feel comfortable in their quality of life and areas where they feel something is lacking in their quality of life. And so the goal is to improve that. That's one step. Next slide, please. So we also, and it was on the last slide, we capture a little bit of kind of clinical information. So we ask people, in the previous 2 years before you came in this program, how many times were you hospitalized? And then we also ask people, how many times did you end up in the emergency room because of a crisis? And we keep, information about that. And at the end of the program, we found that the outcomes were amazing. And I'll get to those in just a second because they really were fascinating. The coach serves a double role because they facilitate the support group, but they also teach. So the way the support groups are set up is they're 90-minute sessions, and 30 minutes of it is educational about techniques and social skills and stuff that you can practice in the group or practice at home that will help you in interacting with people on the outside. The coach also works to help find activities in the community because most of the people who are in these groups are people on SSI, and if you're familiar with, the amount of money that people live on with SSI, way below the poverty line, there's no extra money for social activities. So the coaches try to find as many things that are free in the community as possible, different kinds of activities. Next slide, please. So the other thing we do is each individual gets a small social budget in the program. And depending on the amount of money available for the program, it's somewhere between $35 and $60 per month. And that's called a social budget. And that means that people can only use it for social activities. And they have to develop a plan. So they develop their action plan. They also develop a spending plan. So, for instance, the lady going to Starbucks, part of her budget was spent on buying her favorite drink, beverage at Starbucks, so she could sit there and maybe have a snack, too. To her, this was huge. And the budgets are done on a monthly basis. So the reason why we chose 60 as the cap was because people on SSI, that was an amount of money they could receive with no effects on their benefits. And people are very worried about, losing benefits. So they use that budget and they keep track of it, and it's their responsibility to say how they're going to spend it. And at the end of the month, they put a report into the group that shows how they actually did spend it. And then they can change those budgets during the course of the month, but they have to inform the group. This is all kind of groupthink. Next slide, please. So I kind of went through all this already. So next slide, please. So the outcomes are what I was talking about. So 75% of the people who went through the first 2 rounds that we ran in these groups, year-long each one, 75% of the people said that they had achieved their primary goals and were going to continue on with community activities. 75% of people. And the other people, the majority of them, wanted to continue to work to achieve those goals. And we did keep track of people for a number of years, and we would hear about their successes, and it was just always so interesting that people had built these new habits by reproducing them through a group effort and going out into the community, following a plan. They had created new habits that lasted. and change their life. We also looked at rehospitalization rates, and we saw a reduction of 70% in the year the program compared to the rates of the prior 2 years. So we looked at each year individually and took an average for the prior 2 years, and then we looked at the amount in the year that they were in the program. 70% reduction in the use of rehospitalization and 70% plus reduction in showing up in emergency department and emergency rooms due to crisis. The other thing we looked at was satisfaction, and 95% of the participants said that their experience with the groups rated at the highest possible score. Next slide, please. So the other thing I want to talk about quickly is it's called the Temple Collaborative, and this is another place where you can go to find programs that can help people. Peer supporters can utilize these programs to help people feel more included in their communities. Temple University has created this collaborative with a number of groups around the country, and it's become a kind of a storage database for social activities and tools that people can use. Next slide, please. So the goals of the collaborative are that it targets obstacles that keep people with, and these are their words, with mental illnesses from being full members of their communities. It identifies the supports that people need to enhance their prospects for real community integration. And then it expands the range of opportunities for people so that they find more things they can do. So it's essentially doing really the very same things as the Peer Partners program. Next slide, please. They have all kinds of evidence-based resources available, and it's really worth going on. The address is here, and you'll be able to pull up this webinar, but really all you have to do is just Google Temple Collaborative, and you'll find a wealth of information. One of the resources they did is a toolkit called Jumpstarting Community Inclusion, a toolkit for promoting participation in community life. This is really good. It has 66 practical steps that people can take to begin to build community integration and inclusion. And it also has steps with it has links to 100 other publications and products that people can use for these same efforts. And that's available for free on the Temple Collaborative site. Next slide, please. And the Temple Collaborative, when they first kind of came together, they were trying to figure out how they were going to assimilate all this information. And in 2016, they issued a report about the kinds of materials that they had gathered and what the results of those tools have been. And so it's also available, their report from 2016, and it will tell you about the successes that they've been able to really see and to measure about how people are better equipped to engage when they learn a few simple skills. Next slide, please. So this is a really good one too. This is a publication they put out a few years ago that is specifically for peer specialists to use, and it's called the Peer Facilitated Community Inclusion Toolkit. And it's got dozens of programs in them. They're in all kinds of different areas. In fact, I think if we look at the next slide, you can see where some of the areas are. Well, they did it with the self-help, the Consumer Self-Help Clearinghouse. And so it's a 50-page compendium of over 36 different programs. And it really provides something that nobody else has been able to provide, and that's being able to go to one place and try to find something that fits your needs, either as an individual or your needs as a group. Next slide, please. The compendium, what I was talking about before, here's what I was referring to, is it deals with programs that are in housing and employment, family life, religion and spiritual life, leisure and recreation, civic life for people who want to be involved on that level, healthcare, finances, and community integration itself. So it's very, there's tremendous depth in these programs that you can really make use of. Some of them are a little older and they need to be updated to fit into a program that you might be running, but they're very valuable. Next slide, please. So just to wind up about the Temple Collaborative, they have expert researchers, but they also have individuals with lived experience, and they also have policymakers and provider agencies involved in assembling all of this information and interpreting it and reorganizing it so people can best use it. They say that they seek to target obstacles that prevent people with psychiatric disorders from getting their maximum experience, to develop services and supports for people so that they can connect with the world around them, and to expand the number of opportunities that each person has available to them. And really, that's what we all want. If you think about it, that's what we do as individuals. If you've ever been in a situation when you've gone into a new job, or maybe you've moved to a new place, the first thing you try to do is find something that you like. So you're targeting different ways to connect to that new community. And then you're developing your own style that you're going to use in connections. And then you expand that beyond to become a full-fledged member of your community. It's the way humans interact. And as I said before, it's part of our evolution. So finally, next slide, please. I'd just like to say we really are beginning to see that American society is impacted to the same degree as the United Kingdom, as other European countries, but we're just beginning to deal with it on a real national level. In the last 2 months, I have heard read six articles, or there was a piece on NPR, National Public Radio, and I've seen it on network TV about loneliness and what it's doing to society, and the cost to society both on the human level and on the economic level, and the way that it will influence the future of our own society. So peer support can be a really wonderful tool to help in the feelings of exclusion and also the other reasons why we feel loneliness. And this is something that we need to confront, so I encourage each of you, if you're working in areas where you can make use of these kinds of tools, to access them and start to do work. Mental Health America is going to do a lot of in-depth programming over the next year. We have planned to have a real nationwide event, online event this summer, where we will present not only the science of what's happening when people are excluded or feel lonely, but also the science of what happens to people when they are reconnected. And then we're going to hear about real-life examples from people who have gone through these experiences and then found their way back to community. So I thank you very much for your time, and I think we have some time for questions.
Yeah, thanks, Patrick. We do have some time for questions. So like I said earlier, go ahead and type them into that Start Meeting chat box. Some final notes while you guys get those in. So SMI Advisor is now available from your mobile device. You can use the SMI Advisor app to access resources, education, and upcoming events, complete mental health rating scales, and even submit questions directly to the team of experts. You can download that at smiadvisor.org/app. And if you have any follow-up questions about this or any topic related to evidence-based care for mental health, clinical experts are available for online consultations. So any mental health professional can submit a question and receive a response from one of their SMI experts, and consultations are free and confidential.
Let me just add something to that, too.
Sure.
I'm actually a member of the SMI team, and it's not just professionals that can ask questions. Anybody can ask questions on the site. The site is divided into two parts, but you can go through either one. One is directed at clinicians, and it's about best practices. So it's a lot about psychiatry and psychology and social work and, clinical practices. But then the other side of it is about individuals and peer support and recovery and families and caregivers. And so we are building up a lot of information that will be available to people kind of across the board, people who are struggling. They're struggling with symptoms. They're struggling perhaps with even treatment. They're struggling to find friends. They're struggling to find a place where they fit in. And we are available through the SMI website, SMI Advisor website. And we welcome you to come and make use of it. This year, we're going to be adding a tremendously expanded amount of information for peers and for caregivers. So go ahead, Emily.
Great. Thanks, Patrick. SMI Advisor is also just one of many SAMHSA initiatives that are designed to help clinicians implement evidence-based care. So you're encouraged to explore resources available on the Mental Health Addiction and Prevention, TTCs, as well as the National Center of Excellence for Eating Disorders and the Suicide Prevention Resource Center. These initiatives cover a broad range of topics from school-based mental health through the opioid epidemic. So there's a lot of information there that you can also find. So as for questions, it doesn't look like we have any in yet, but there's still a good amount of people on the webinar. So we can hang on for a few minutes. If you have anything you'd like us to chat about, go ahead and pop it into that chat box there. Not a question, but a few people have mentioned that they want more information on all of this. And like Patrick said, we're kicking off an initiative this year looking into loneliness and social isolation a lot more. So just stay tuned with our Center for Peer Support site, and I'll keep this contact list to send you all the recording and slides out and any other information that we have to send you.
And like Emily says, if you go on, it's a site within the Mental Health America site, but you can go directly to it. It's Center for Peer Support, one word, .org, and it'll take you directly to it. And it's really got tremendous depth of information about peer support, about trainings, about certification, evidence, many, many different reports and articles written about it, things about the things that we've been talking about today. And that's where we're going to be adding more and more information about social connections. Any other comments?
Nope.
Well, again, thank you, everyone. And I guess we get off early today, and I really appreciate you attending. Take care.
Thanks, everyone.